do have our next session about to get underway. An update on the fetal surgery. I'd like to hand over to Dr. Mandeep Singh, who will take us away on the next session. Over to you.
Thank you. Thank you very much. I'm just going to give you a brief update about fetal surgery and the work that we've done. This is me. We established the Fetal Surgical Center almost 12 months ago.
But will also increase our abilities to impart education and training programs within the UAE region.
And the procedures that we're going to talk about is open spina bifida repair, congenital diaphragmatic hernia,
will have three
fetal
arms:
shunts and fetal
molecular
transfusions.
diagnostics,
Now,
cellular
just for
technology
everybody to know,
section,
spina
and the
bifida
transplant
is a
diagnostic
defect
lab.
in the spine which can be diagnosed at 20 weeks gestation. It is very easy to diagnose by an ultrasound scan. The incidence is different in different parts of the world. It's around 10 to 20 per 1,000 births. And it's a defect in the lower part of the spine where the spine is exposed. And in the olden days, this is a picture from 1805. So it's a disease of a it's been there with human beings for a long time. This was first described in a paper in 1805, and that time they tried various things like tying the defect, cutting it, or putting injections into it. This is the oldest form. But we know as ultrasound imaging progressed and became better, by the end of by 1973, we could see spina bifida on ultrasound scan. And now scans have got much better. That is why diagnosing spina bifida is very easy. To diagnose spina bifida, you don't have to look at the spine. All you need to do is look at the head. And the head, the cerebellum looks like a banana, and the head is like a lemon. And that is why we call this as a lemon sign and banana sign. Just by looking at the lemon and the banana sign, you can diagnose open spina bifida in almost every case. And that is really important. It is important because if we diagnose spina bifida early, then we can do something about it. It's important to do something about it because babies who have spina bifida, by the time they are born, the amniotic fluid has damaged their spinal cord and they lose control over the bladder and the bowel. And if the spina bifida defect is slightly higher, then they lose power in both the lower limbs. So these babies are born with loss of power in both limbs, loss of control over the bowel and bladder. And if you look at that picture, it shows you that the lower spina bifidas are more common. So lumbosacral 75, sacral is 24%. And because of the spinal defect, the cerebrospinal fluid or the fluid around the brain accumulates in the sac, and that causes the brain to be pulled down. And that is described as Arnold-Chiari malformation. Because the brain is pulled down through the defect, these babies need to have a shunt operation when they are born. So the babies have three problems: loss of bowel and bladder control, loss of power in the lower limbs, and babies have more fluid in the brain, so they need a shunt that will drain the fluid from the brain into the abdominal cavity. Obviously, something needs to be done for these babies, and what this slide shows is that if we don't do anything, the 5-year mortality rate for these babies is 35%. So 4 out of 10 babies with this condition will pass away within the first 5 years. And 20% of these babies will die within the first year of life. And the remaining babies will have lot of morbidity, which is related to loss of bowel and bladder control and loss of power in the lower limb. Now, if you look at this picture, this is a normal spinal cord. And in babies with spina bifida, because of exposure to the amniotic fluid, look at what that F slide shows. There is complete dissolving of the upper part of the spinal cord by the amniotic fluid, resulting in this damage. And that is why it is important that we do something about it. This is a picture from 24 weeks, and this is a picture from 37 weeks. So by the time the open spinal cord reaches from 24 to 37 weeks, it's completely damaged. So we thought, why not repair this inside the womb? Why not repair this at 24 weeks? Because then you can prevent the damage. So, but it's not about us thinking. The first trial, which is also called as the MOMS trial, started in 2003 and was completed in 2010. And this showed that if we repair the spinal cord inside the womb, then it reduces the need for a ventriculoperitoneal shunt by 40%, hindbrain herniation by 30%, twice more like babies are likely to walk independently, and 2 times more babies are likely to have better control over the bowel and bladder. But obviously it's a big operation. It's an operation where you open the womb and then you repair the baby's spine. Hence it can be associated with the risks, and the biggest risk is the risk of preterm labor. Because we are operating on the womb, there is a 50% chance of going into labor early. However, the effect is very important. Now these are some scan images. You can see excess fluid inside the brain. This is the excess fluid, which is again shown in this spine. You can see the spinal cord. This is the lower part of the spinal cord, and you can see the defect on the top of it. You can see how the defect looks like on the spine. And this is a very easy diagnosis to be made. What we do is open the uterus, we cut the amniotic sac, collect the amniotic fluid, and then suture the spinal cord, cover the spinal cord in 3 layers. The first layer is the sac, second layer is the muscle, and the third layer is the skin. I guess it is a bit graphic to show the images, but once we have done that repair, these babies, we have done 8 repairs in the last 1 year. All these babies were born after 34 weeks, and these babies are doing well. Out of the 9 procedures that we lost 1 baby because that baby delivered early, and early delivery with spina bifida babies are not going to do well at all. So that's one success story. We are the only center in the UAE and outside Europe that can perform spina bifida. The second story is about diaphragmatic hernia. Diaphragmatic hernias are where there is a defect in the diaphragm. Diaphragm is a small thin membrane that separates the abdominal content from the lungs. And when there is a hole in that, then the stomach and the intestine all come into the chest, and that compresses the lungs. And if the lungs are compressed, then the baby will not be able to breathe when the baby is born because the lungs will not develop. Now what we do is, this is an example of how the diaphragmatic hernia looks like. You can see the heart and you can see the stomach next to the heart. So the stomach is now in the chest and is compressing on the lungs. And this baby, when the baby is born, will not be able to survive. Now, not all babies with diaphragmatic hernias have this problem, but only moderate and severe diaphragmatic hernias have this problem. So we use this calculator to decide whether it is a moderate or a severe defect. And if the defect is moderate or severe, what we do is we put a balloon in the baby's trachea. This is done at 27 weeks. So we anesthetize the baby, we put in a scope and put in a balloon at 27 weeks. When we block the trachea, what happens is the fluid inside the lung starts accumulating and the lungs grow bigger and bigger. And when the baby is born, these lungs are much more well developed than if we left them alone. Obviously, we need a trial to be able to prove this. So the first trial, which is the total trial, was published in 2021, and it showed that babies who had this intervention did much better than babies who did not have the intervention. More babies survived, more babies were discharged home, and hence what we do is we use these special instruments. We anesthetize the baby, we give a muscle relaxant and a painkiller, we go into the mouth and then place a balloon in the trachea, and then this is the first step. We then allow the baby to grow, we allow the lungs to grow, and then at 34 weeks, we go back and puncture the balloon, and then let the baby deliver at 37 weeks. And you can see that this is the lung before placing the balloon, the small lung. And then you can see what happens to the lung once the balloon is placed. You can see the effect. The lung, which was not seen, is now clearly visible after the balloon is placed. And this effect actually saves lots of babies. Now, the third story, and we have done 2 procedures. One of the baby did not have a diaphragm on the left side at all. This baby is now about to be discharged. The chances of survival of this baby were only 10%. And this baby was of a lady who had undergone an IVF pregnancy. Obviously, every baby is precious, but for this lady, that was her only chance. And this baby is doing extremely well. Now, the third story is about fetal shunts. Now, this is a lady who came to us at 22 weeks. This is the lung, and you can see the lung is replaced by large sac filled with water. And this sac is now compressing upon the lung, the heart. You can see the heart beating on that side. The whole lung is replaced by the sac. And because the heart is pushed, this baby is accumulating a lot of fluid in the abdomen, under the skin. And if we don't do anything to this baby, the baby will pass away within the next 3 or 4 days, because this baby is severely under serious heart failure because of the compression. Again, this was the first baby, first pregnancy. And we knew that the baby is under stress because of the cyst. So what we did was we put in a tube or a shunt into the baby's chest and see what happens when we put the shunt in the chest. The heart is now bigger. I will show you. The shunt is these, you can see these tubes on the chest. And those are the shunts, those tubes that are carrying the fluid from inside the lung to outside. That causes the heart. You can see the next image where all the fluid has been reabsorbed. The lung is growing, the other lung is growing, and the heart is recovering back to normal. This baby then delivered, these are the shunts that we use. These are tiny plastic tubes that we place in the chest and can help these babies survive. You can see the shunt, that's one of the shunts. And obviously the shunts have complications, but everything, but these were managed very well. This baby is also at home now and delivered at 35 weeks after placing 2 shunts in the chest. These are success stories. Obviously it's a long way to go. We also do something called as laser separation of placenta in monochorionic twin pregnancies, where there is one placenta. They can sometimes develop twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome is where there is an imbalance in blood flow. One baby gets more blood, second baby gets less blood. We classify it based on this. And what we do is we put in a camera a scope and burn the connections on the surface of the placenta. When we burn the connections, that separates both the babies, and both the babies start growing. These are the connections that are causing the imbalance in blood flow. We use laser to cut those connections, and these babies do well. I think I have a video, obviously because it's an open space. A lot of my videos have been deleted because they were not fit for to be shown here. Obviously, sometimes we have to let one of the babies go. These are the graspers that we use to cut the umbilical cord. But these are some of the stories of fetal therapy that can give life to babies that the world has said, well, we can't do anything. There is no such thing in fetal medicine now where we can't do anything. It's just about us accepting that, yes, we can give hope to these babies. Thank you. Thank you. Any questions? Hey, Max.
So how do you train for these procedures? Because they're very rare procedures, and you want to make sure that you obviously deliver very good quality care. So how do you train for these?
Absolutely, and I wouldn't advise anybody to start a center without appropriate training and support. So I first trained in a center that was doing many such procedures. After being certified by them, I did not do it on my own. We get surgeons from outside to come and help us. And one thing we had promised everybody is that we will keep our results open. We will not hide any of our results. So anybody is welcome to come and see our outcomes, because that helps patients be motivated enough to accept them. And I think that's the right thing to do. Any other questions? Thank you.
Perfect. Thank you very much. Dr. Singh, that is our final session for today. If you've got any further questions or you'd like any further information, feel free to scan the QR code inside the stand to get a little bit more information, but we will be back tomorrow with some continued sessions. Thank you very much.